We've invited some additional frontline healthcare workers, patient advocates, and a representative from California OSHA to describe their experiences with infection prevention and control. First to speak is Dr. Andy Bowdle from the University of Washington.
Thank you, Lisa. My name is Andy Bowdle. I'm a cardiac anesthesiologist. Some of my colleagues and I have been wearing N95 respirators throughout our hospital since March of 2020, and we continue to do so today. We have also been using portable HEPA-rated air purifiers in our offices during the same time period. During much of the COVID-19 pandemic, our respiratory precautions were not in agreement with the policies of our institution and are not in agreement with the current policies of our institution. However, we were convinced that the risks of aerosol transmission from the beginning of the COVID-19 pandemic. I speak today for myself, but also for many of my coworkers. In addition to protecting ourselves, we are very concerned about protecting our patients, many being elderly, immunosuppressed, and with other risk factors. We have seen patients become infected with COVID-19 while hospitalized, and some of those patients have died of COVID-19. We believe that in many instances, these patients were not protected as well as they could have been. We are concerned not only with COVID-19, but with all of the other aerosol transmissible diseases. We believe that during times of substantial prevalence of aerosol transmissible diseases, including the current moment with COVID-19, there should be universal masking in healthcare facilities. And by masking, I specifically mean respirators, such as N95, whenever possible. We believe that we have an obligation to patients to protect them to the best of our ability and also to our healthcare coworkers. We strongly believe that CDC guidelines for infection prevention should recognize the need for the frequent application of effective respiratory protection during the routine conduct of healthcare, recognizing that aerosol transmissible diseases are frequent and common threats. We strongly support additional research to improve the effectiveness and tolerability of respirators, to include further development of elastomeric respirators for use in healthcare settings. Ever since the HIV epidemic, we have accepted the need for standard blood-borne precautions. Now that we fully appreciate the significance of aerosol transmission of respiratory and other diseases, we need to also accept the need for routine respiratory protection in our healthcare facilities. Thank you.
Thank you very much, Andy. Our next stakeholder speaker is Jennifer Ritz-Sullivan, a patient advocate. Jen?
Hello. As stated, my name is Jennifer Ritz-Sullivan. I am disabled and chronically ill, and I'm fully aware of the devastating impacts of aerosol transmissible viruses, particularly COVID. I lost my 66-year-old disabled mom, early dawned COVID in December of 2020. She contracted the virus from a household member who did not wear a mask. My mom died because of someone's decision not to mask. My husband works at a high exposure job and is frequently the only person with a respirator. We caught COVID through one-way masking from his job this spring when cases were considered relatively low. One-way masking, as you've heard, is not safe enough for high-risk folks or for anyone. So despite being up to date on vaccines and having access to Paxlovid and numerous over-the-counter medications, it is the sickest I have ever been, and I remain high risk for the same disease that killed my mom. I haven't fully recovered, and I am now further disabled by long COVID. I did not consent to COVID, and neither did my mother. My healthcare center dropped masking in May. Although there are some medical needs I am able to put off until it's safer, I still require frequent office visits. I requested that my providers wear respirators when meeting with me, even offering to supply them. And I was told that they only need to wear surgical masks if asked by a patient, as they go by CDC guidelines. Surgical masks worn by a few providers in a large healthcare facility are insufficient to protect me or anyone from aerosol transmissible diseases. Every visit requires prompting, advocacy, and risk, which all deplete me. With my masking request at the top of my file, I still have to state the request when I book my appointment, when I arrive for it, and when I meet the physician's assistant. I've had providers become rude to me the second I ask them to mask, huffing, rolling their eyes, and only wearing a surgical mask under their nose the entire time, as if they've never worn a mask before. No one should have to risk disability or death to receive medical care. We need increased universal guidelines for the safety of everyone. And we must learn from the dead and disabled, and we must do better. Thank you.
Thank you very much, Jen. Our next speaker is Eric Berg from California OSHA. Eric.
Right, thank you very much. Yeah, my name is Eric Berg. I'm the Deputy Chief of Health for Cal OSHA, and my group is responsible for writing the occupational health regulations for the state of California and the California OSHA program. So going back, in February 3rd, 2020, 1 month after the first reports of the COVID outbreak, Cal OSHA issued written guidance for COVID-19. Cal OSHA stated that workers must be protected from COVID-19 through use of airborne infection isolation, NIOSH-approved respirators, source controls, specific training, and several other protective measures necessary for airborne infectious diseases. These protections were, back then, and they continue to be today, mandatory for workers exposed to COVID-19 in healthcare, correctional facilities, and many other types of facilities, service categories, and operations. These worker protection requirements are the law in California due to the Aerosol Transmissible Disease Standard, or Title 8, Section 5199, established in 2009, many years ago. This law covers many infectious diseases, including diseases caused by novel pathogens, such as SARS-CoV-2 and unknown pathogens. CDC, unfortunately and erroneously, did not recognize COVID-19 as airborne in 2020 and issued guidance that was much less protective than California law. This contradiction created confusion that resulted in some workplaces not complying with the California ATD standard, and then as a result, suffering from deadly outbreaks. Forgotten in these workplaces was the fact that California law prevails over CDC recommendations or any other recommendations that are less protective than the law. Also, disposable respirator shortages occurred in 2020. Cal OSHA and many others urged employers to use respirators specifically designed to be reusable, which were not in shortage at the time. Unfortunately, other entities put into practice the reuse of disposable respirators, which were never designed nor made to be reusable. This resulted in inadequate protection for workers and new hazards for workers. Moving forward to the present, we know from extensive studies by NIOSH and many others that only respirators can protect against fine and ultrafine particles that can carry airborne infectious pathogens. And it's very easy to test how much protection a person gets against airborne particles using a respirator. This is done using quantitative fit testing that has been in OSHA and Cal OSHA law for many decades. Half-face respirators, such as N95 respirators, when using a quantitative fit test, must achieve a fit factor of at least 100 pass the test. Studies have shown that surgical masks will provide a fit factor of 2 or maybe 3 in quantitative fit testing. The protection provided by a surgical mask is 33 to 50 times less than that provided by even the most basic respirator when used properly. To state there is no difference in the effectiveness of a surgical medical mask and a NIOSH-approved respirator to prevent transmission of airborne diseases is false, is unacceptable, puts workers in danger, and is not supported by science. Again, California law in the past and in the future will require workers to be protected from airborne infectious agents with airborne infection isolation, NIOSH-approved respirators, source controls, and many other protective measures. This will not change. PICPAC and CDC recommendations, which are less protective and contrary to California law, will serve to create confusion and pretext for some to not adequately protect workers. The scientific community, public health professionals, and health advocates should let CDC know that undermining worker protections with unscientific reasoning is not acceptable. Thank you.
Thank you very much, Eric. Our last speaker in this session is Kimberly Wills O'Connell, a critical care nurse.
Good afternoon, everyone. Again, my name is Kim O'Connell. I have been a critical care nurse for more than 30 years now, working in the Philadelphia region. My story isn't unique. In fact, it's been a story echoed by hundreds of thousands of healthcare workers since the announcement of the pandemic in the spring of 2020. What started out as an outbreak abroad quickly escalated to a global pandemic in September of 2020. There was over 1 million deaths reported. 6 months later, the number had doubled to 2 million. And by February of 2023, more than 7 million people had succumbed to the perils of COVID-19. It seems unfathomable that in the richest country in the world, that we account for more than 70% of the world's death toll from this preventable illness. Sadly, it seems the consensus is the answer lies with our blemished bureaucratic leadership. Instead of employing the scientific research to guide reasonable recommendations for others to follow, governmental agencies tasked with protecting public health and safety politicized the crisis and promoted vast mixed messages about viral transmission and the appropriate mitigation strategies, which created immeasurable chaos and mistrust. Essentially, by choosing not to take the precautionary measures to recognize COVID-19 as an aerosolizing transmittable disease until May of 2021, the CDC and like agencies recklessly facilitated the unnecessary infection and deaths of thousands of healthcare workers and patients throughout our nation. Those who had taken an oath to serve and protect our society abandoned us. As frontline healthcare workers, I speak for myself and my colleagues, we were unarmed warriors sent to fight a hopeless battle with no leadership. What we endured was isolation. No one came as we walked through the halls, masked day in and day out, paralyzed by our fears, but committed to our jobs and our patients. We battled with our leadership and begged our community through social networking for N95 masks, face shields from Amazon, trash bags doubling as isolation gowns, and clean gloves that weren't utilized previously. No one came to the bedside from our government officials as we tried to reassure families by the telephone about their loved one's arrival when they were not permitted to visit, and we knew they would never leave. When we FaceTime families to try to maintain some human connection, and again, when we attempted to resuscitate them after weeks of futile and torturous care. No one came when our patients realized they were dying and would never return to their beloved families. And the most we could do was offer the assurance we would stay, hold their hand, and make sure they did not die alone. For families, there was no closure, no goodbyes, no explanations to what happened. For nurses, we feared for our lives, but even more for our families, making the decisions to stay in different living areas or not seeing them at all, living in isolation with only our thoughts, recounting the deadly horrors we witnessed and would inevitably repeat in a few short hours. The emotional scars from our experiences cannot be erased. We cannot go back in time. We can only move forward, committed to making certain the tragedy of COVID is never repeated. As the advisory committee tasked with providing the isolation precaution guidelines, we want you to have the obligation to rectify the damage and mistrust you've created by being transparent and disclosing the science being considered to formulate your decisions, and be open to the outside contributions from panels such as this to guarantee your commitment to protecting our community's public health and safety for the future. Thank you.